is biocompatible, zirconia is biocompatible, and you always see some images of the cells of these abutments in the background. And there is also evidence that the peak is biocompatible. Also the alumina, but now we don't use anymore too much the alumina because it's too fragile. But these are really three of the materials we can use transgenially. Of course, for the peak, at this stage we would not use it as a final component, but sometimes as a temporary one. But all these materials, the lithium disilicate, the resin, PMMA, chrome cobalt, all these materials, there is actually no evidence that they are biocompatible. And the in vitro studies that are existing are actually suggesting that they do not allow cells grow as the other ones, as the titanium or the zirconium. So this is why I would not advise to use these materials subgingivally or transmucosally. I mean on a bone level implant. On a tissue level implant, where you would have the establishment of the biological width of the implant neck. That would not be a problem, of course. But on a bone level implant, I would not use these materials submucosally. And I think still lots of practitioners are doing that, and we have to be aware that there is no evidence that this is really biocompatible. And in our group in Liège, we actually very concerned about that since quite a few years. And at some point, because there were actually no human data about the effect of the material on the muco-integration, on the integration of the periplate soft tissues, that we decided to start a significant, a big project where we develop a model to harvest. We developed some experimental abutments that we placed directly after implant placement, and these abutments are very narrow. And after 2 months, we harvested, we did a little biopsy, we harvested the soft tissue around the abutments in order to study how they react and what is the interface with the abutment. So we did several analyses. We first of all studied 3 materials at this stage, so titanium, PEEK, and resin. And for the resin, it's quite difficult to find a model because we cannot really do an abutment in PMMA. This is too fragile. But we actually used the glue from a composite. So this is why it's not PMMA but more resin. And this is a big project that is actually supported, it's a grant from the ITI. And some of them we harvested both the tissue and the abutment, and we did non-decalcified histology. So it's really cutting through the abutment and the soft tissue. This is something we're doing together with Tito Bossard from the University of Bern for the histology work. And other specimen, we actually detach the abutment from the soft tissue, and we look on the one hand on the soft tissue, and we look at different markers for inflammation. And on the other hand, we also looked at the abutments, with the electronic microscope. So it's a big, let's say, randomized control trial, and our plan is actually to continue the study and to have other series of patients where we study different materials, but now I have just the data of this one. And we also look at the bone remodeling. This is the bone loss here directly after 2 months. And if we compare the 3 groups, we look at different parameters, Of course, the clinical parameters are the plaque and the visual level of inflammation. We didn't probe around these abutments because, of course, probing would have disturbed the attachment of the mucosa. But we look also at plasmacyte, B cells, T cells, macrophage, neutrophils. And basically, I'm not going to go into the numbers, it wouldn't make sense really. But here I just, illustrate with some green, which is the positive result, and the red that are more the negative results. And what we see is that for the resin group, so basically material that we use very often for provisionals, it behaves well in certain aspects, but we see more neutrophils, first sign of inflammation. We have more macrophages. So here we can discuss, because there is actually with macrophage, there is the good guys and the bad guys. There is the good and the bad, and with the type of immunohistology we did, we cannot really differentiate these two types of macrophage, but still there is more macrophage with the resin. And finally, with the resin, there is more bone loss. Bone loss after 2 months. So this is early bone loss that we suppose is associated with probably the impossibility or the compromising of the establishment of the biological width on the abutment of the resin, and an apicalization of the biological width, inducing a physiological remodeling. So this is not published yet, we're working on the manuscript, so this is very fresh data for you today. Considering these results, I would be, again, very careful with using resin on provisionals, directly on bone level implant, and because it makes sense to do like a resin crown or PMMA crown provisionally, but then I would always use like a titanium base or a provisional abutment, not of 1 millimeter, but of 3 millimeters. That at least we have 3 millimeters of titanium, and then the resin. And we will see some clinical cases today and tomorrow on how to do screw retain provisional, being soft tissue friendly, let's say. Another material that is definitely not biocompatible is the cement. And the cement remnants, they are problematic. I am sure that most of you have already been facing this problem. What's happening here when we have deep limits is that sometimes when we cement, it's just impossible to remove the cement fusion. And basically we have this cement fusion invading the biological space, and then you have an apicalization of the biological space and of the bone. And this is, like an open door for further problems. So it means that, like with this, you can definitely induce periimplantitis. So this is not a periimplantitis that would be induced directly by bacteria, but it would be indirectly induced by first the door you open, the cement fusion, and then a secondary colonization of the surface by the bacteria. So Thomas Linkevicius, he also published a lot about, a few articles at least, on the influence of the depth, the limit on cement fusions and complications related to cement. So he showed that if your limit is more than 2 millimeters under the cervical level, you expose yourself significantly more to these problems. And actually, to me, 2 millimeters is still too much. If you decide to go for a cemented restoration, which you have to do sometimes, especially when the angulation of your implant does not allow to do screw retain. If you go for that, you need to use individualized abutment. Custom-made abutment where the limit is going to be juxtagingival, or maybe slightly subgingival, but 0.5 millimeter, 1 millimeter maximum, to my opinion. In order that you're really able to remove properly all cement remains and really try to avoid these type of complications. So, because of it is well known, these complications we can have with cement, more and more the industry and even the colleagues, and especially the restorative dentists, they prefer and they advise to work with screw retain restoration. And it makes sense. I agree with that. Here, this is another example how, you know, when we do screw retain restoration, in order we have to make sure we have biocompatible materials transgingivally, so we have the raw zirconia transgingivally, and the veneering ceramic is just supragingivally. But we have to also keep in mind that when we have biocompatible material transgingivally, and when we have the establishment of the muco-integration, I'm talking here about bone level implants. Again, soft tissue level implant is not a problem. When we unscrew the components, we also inducing a rupture of this muco-integration. We're inducing a rupture of the soft tissue sealing. And here is an example of it's a provisional crown that I place in the mouth of my patients during the ortho treatment. So this component, this crown was for several months in the mouth of the patient. And so this is why I made sure to use a biocompatible material transmucosally. This is here like a titanium abutment. And the crown was like the resin or PMMA. And when I remove it, what you see is that, you know, this whitish layers there, it is not plaque, plaque doesn't look like that. It is really the cells, but this is really well organized now here. And when you look at the electron microscope, this is cells. This is epithelial cells that are really integrated, adhering with ebidesmosome to the component. And here in the side, it is actually bleeding. It is not bleeding because it's inflamed. It is bleeding because I have created a wound. I have basically disrupted the epithelial cells from the connective tissue underneath. So I basically expose the connective tissue, which contains blood vessels, while the epithelium does not contain blood vessels. So basically when we remove a healing abutment or a provisional crown or even a finer crown from a bone level implant, where we have a proper soft tissue integration, we are creating a wound. And if we do that several times, this muco-integration gets tired of this. And again, the biological width has the tendency then to go apical on the neck of the implant. And we may induce an early bone remodeling. That may be an open door for further complication. So look, this is here like a little bit histology. So you see, when we remove the abutment, the blue cells, the dark blue cells, they are the epithelial cells. They tend to stay adherent to the abutment, and this is exposed. This is the connective tissue, and we have really the rupture between these two types of tissue. And basically, repeated unscrewing would lead to an early bone loss that might be an open door for further complications. And now in the literature, it is not here, never unscrew the supragingival part. And if we have to do it, we have to reduce the number of disconnections. And according to the available literature, we could say it should be less than 2 times that we disconnect. And if we disconnect, maybe we also place, you know, the component in saline that the cells do not die before you put it back. Or you clean properly the abutment, hoping that you would have a new muco-integration developed that established. Next point is the design of the abutments. So you've seen in some of the cases I've showed you today already that we like to have abutments that are narrow at the, you know, at the neck, just to leave some space for the soft tissues. If you go for something very flared, you are going to make the soft tissue, the perimplant soft tissue, more thin. And this is not what we want. Also, when we do that, when we do something concave transgingivally, we allow for an organization of the soft tissue a little bit like a ring, like a bell, you know? And it provides thickness, but also like vertical stability. And it is in a way a compensation of the weakness of the perimplant soft tissues. You remember on the natural tooth you have really the sharper fibers, and here you would have like another type of anchorage that is more like a ring. And here this is again some very nice images from Peter Schubach. So this is an example of this type of transgingival profile we like to have, something like concave, especially on the buccal side. It is true that, and I don't know if this makes sense, but we still prefer to have something a little bit maybe supportive of proximal to support the papilla, but in the most important area where we have eventually recession occurring, which is the buccal side, we have something where we leave as much thickness as possible. But we need to have a proper critical contour. So Oscar Gonzalez is one of my good friends from Spain, and he has developed a lot on the provisional management and described, well, you know, the subcritical contour, which is the contour which is submucosal, you know, and that can be basically narrow, where we want to leave space for the soft tissues, and then the critical contour that should be designed ideally according to the expected anatomy of the tooth, and according to basically the aesthetic analysis. When talking about abutment, we also need to talk about abutment cleanness. And yeah, we have to understand that when abutment comes from the lab, but even when they come from the milling center, when they come from even the company, they have stainings. They have stainings, little black dots when you look here at these images in the electronic microscope. They are mainly organic compounds that come from the milling thing. This is basically fat, oils, and yeah, honestly, I'm not very comfortable to place these in the mouths of my patients, even though we have no evidence that they are really problematic. But if I can, in a simple way, clean them properly, I would definitely do it. Of course, it should not be a protocol that takes an hour and that does involve lots of cost. It should still be something simple. And actually, different people have looked at how to clean them, and some propose like a 45 minutes protocol investing in plasma and in expensive stuff. And we basically, in our group, applying a protocol since a long time, which is like ultrasonic bath. And I'm sure most of you have them for, you know, cleaning different material and stuff. And we put them in a pot, you know, we have 3 pots. One with a cleaning agent. Cleaning agent means a soapy agent, like something that is going to remove the fat. Then another pot with sterile water, and another pot with alcohol, 70 degrees. And we just put them 2 minutes each, so it takes exactly 6 minutes. Of course, when it goes out of the alcohol, then you need to make sure this is dry, but it dries quite quick in the air. And we basically looked a little bit at the result of our protocol, and yeah, this is what we get. So I personally feel more comfortable to place that abutment in the mouth of my patients than this one. Takes just 6 minutes. So we applied this protocol since years, I would say. And I remember when I presented this to the ITI World Symposium in September, for those that attend that virtually, I got a question. And I got a question, don't you think it works well also with the steam in the lab? And you know what? In between, we've done a study. And it's not, of course, yet published, but we already advanced well with the manuscript, but I do have all the results. I was like, yeah, maybe I should check that, you know? And what we did is we compared this protocol together with the steam, but we did an experimental abutment. We did an abutment, you know, like a zirconia abutment, also glued on a tie base. This is what we do a lot today. And we did a flat part there, and but we asked the lab to mount the ceramic to do all this normal work. We look at them before, and there was lots of stains, there were lots of, you know, that was not very clean. And then we applied 30 seconds apically towards coronal of the crown, 30 seconds with steam on one side, because this was one flat side. We needed to have one flat side to be able to look at the electron microscope. And the thing is that if you do it 30 seconds of steam on each side, so maybe then it takes 2 minutes, we have equivalent results. It's actually working well. But these studies, the ones that were proposing the plasma or some complex ultrasonic bath, they were always comparing to the steam, but they were comparing to the steam, not really describing how. And maybe if the lab just does that in 5 seconds, then this is not efficient. But if the lab does that efficiently long enough, it might be an alternative. But you also have to make sure your lab is doing that the way you want. But yeah, then it answers properly the question I had a few months ago. So to summarize this prosthodontic approach, what do you have to keep in mind? One is that if you work on bone level implant, you absolutely need to put biocompatible materials transgingival. And for the final restoration, this is titanium or zirconium. If you want to work cemented, this is absolutely valid, but you have to make sure that your limits are juxtagingival or slightly subgingival. And finally, if you work screw-retain, which lots of prosthodontists prefer as well because it's a lot easier to manage prosthodontic complications like chipping and so on, then you have to avoid the disconnection on bone level implant. There is ways to avoid completely the disconnection. If you decide to work, you know, like in the aesthetics case with like one single crown, then you have to minimize the number of disconnections. So let's finish then with a few clinical solutions that allow you basically to put all that together. And yeah, one of the what solution can we propose to our patients today? A first option that is definitely still a very valid option, and this is still an option I am using a lot, in the posterior region, is to use a tissue level implant. Tissue level implant, you have the establishment of the biological width on the neck of the implant. Of course, when you place a tissue level implant, the smooth part, the transgingival part, should be supracrestal. Of course, if you place this inside the bone, it doesn't make sense anymore. But the idea of the tissue level implant is that you put the rough surface in the bone and that the smooth surface goes transgingivally. This is here with a TE implant, this can be with a tissue level implant, but that's, and whether you use the titanium or the zirconia, I don't know if there is lots of patients that want zirconia implant here in Vietnam, but again, you see the idea is to place them, I mean, the smooth part transgingivally. Another option that is probably a little bit more versatile, you know, that allows you to play with the angulation and play with angulated abutments, that allows you to use different height. You know, on the tissue level implant, this is 1.8 or 2.8, depending if you use the standard or the standard plus. Here you can have different heights. If you have 4, you can use a 4. If you have, you know, like a 3 millimeter, you use a 3, and so on. So, but the idea here is to place this titanium base. Basically, this is SRA's components. The day of the surgery, so if you're like me doing only the surgery, this is my job to do that. At the time of the surgery, you basically transform your bone level implant on a tissue level implant. You place this component of your choice, depending on the anatomy, and you tight it at 35 Newton centimeter. You tight it once, and you never remove the implant, the abutment again. The idea is that, and then you allow the soft tissue to integrate around the component, and you don't want to disturb this anymore. So that's definitely a way to be soft tissue friendly and to work still screw-retained, because there you work on the tissue level and you can work with the screw-retained components. Now, is there an ideal solution in the aesthetic zone? Because in my practice, I usually don't use the tissue level implant or this space in the aesthetic zone. I mean, I use this a lot, and especially the protocol with the titanium base, with the SRA for full arch, for example. But in the aesthetic zone, I still prefer to use the zirconia transgingivally. I still prefer to have custom-made abutment, as you've seen already in a few of the cases I showed you. And one protocol we've been applying at the University of Liège since a while is the one abutment, the one-time protocol. So we also place the final abutment in zirconia the day of the surgery, if we have a good implant primary stability, of course. We tighten it, 35 Newton, and we never remove it again. And then we work supragingivally, but then with a cemented approach, of course. So this is a protocol that was actually criticized a lot, and here I have some images from a case report that I found in the literature. And what they show is that with this protocol you have lots of cement or glue remnants, and of course then the consequence is periimplantitis. And yes, you expose yourself to that if you use abutment from the shelf, abutment prefabricated, that are not custom-made, that are not individualized, and with limits that are too submerged, too subgingival. Yes, this is the risk. So this is why when we do a one abutment, one-time protocol, for me we should not have stuff like that with deep limits, but we should have something absolutely custom-made. Custom-made according to the gingiva of the patient and with a limit that is juxtagingival. But when you want to do that, usually then you have to take your impression the day of the surgery, and you need to now I know it can go faster with like milling units that are in local labs, but for a long time we had to send this to the major milling center, and it takes like sometimes a week, sometimes 2 weeks, depending. So we cannot really place this abutment the day of the surgery. But more recently, with the digital workflow, we have many new opportunities coming up actually. And now for these aesthetic cases, very often, actually I am able to base on a digital planning, prosthetic and surgical, design and create and fabricate my final abutment or my final abutment before the surgery. And then I have everything available for the surgery. So I show you an example. So basically it's merging the DICOM of the CBCT together with an STL, a digital impression, where the lab is going to do a setup, a digital setup. So of course every case starts with a planning, and start with actually the prosthodontic planning. Once we have the prosthodontic planning, whether actually this is digital or not, in every case, but here in case of digital planification, then I do my virtual implant planning. So we have a case here. You know, this is a case here from a postgrad that graduated a few years ago. So actually, this is the other rare. This is here. You see, in terms of bone, we are in a pretty favorable conditions. And based on the prosthetic planning, she did the surgical planning. And here, the idea, the workflow is this: visit 1, patients you do impression and digital impression. In the lab, we do the planification, the setup and the planification, and then we, based on that, the lab designs the final abutment, the provisional crown, and all this is prepared prior to the surgery, based, of course, on a guided surgery. So we have a surgical guide that will allow me to place the implant in the planned position. Hopefully, something very close to the plan. And then the patient comes for a second visit, and the second visit you can already do everything. Place the implant, place the final abutment, tighten it at 35 Newton, and then never disturb again the perimplants of tissues, and just work progressively with the final crown. And you can also do that digitally nowadays. So this is basically the different steps. You see the lab designs the virtual crown, designs actually the design of the prosthesis, and we have a surgical guide. So this is all we have prior to the surgery. So you see this abutment that is narrowed transgingivally, and this is a provisional crown. This is 2 pieces in this case, right? So this is here the guided surgery that was performed by my postgrad, and this is the placement right afterwards of the abutment, the final abutment. This is tight, 35 Newton centimeter. She directly put the provisional crown, and this is here after a while, after healing, 3 months basically. And this is here then afterwards, the final restoration that was done by a postgrad of the prostate department. Patient was happy, and basically we placed this abutment transgingivally, and we never disturbed again microintegration. So to give you a few words about that protocol, we also did a study here. I actually in the study a little bit more in detail with the group that will stay tomorrow afternoon. What we did, actually, we compared this workflow I just showed you, where basically we do the digital workflow and we provide the final abutment and the provisional crown the day of the surgery. And we compare to actually a more conventional workflow, what we've been doing for many years. So placing the implant with a normal guide, you know, free-handed, but still with a normal guide. Take the impression the day of the surgery. Wait 1 week to get the final abutment. Place the final abutment then 1 week later. So in between, the patient had a little flipper. And then also the provisional crown. To make a long story short, basically what is important to understand from that study, it was a randomized control trial. It's actually already published in, I don't remember the journal. We have, according to the planning, because we did a digital planning with all the cases, we always had a better accuracy with guided surgery than with free-handed, but it makes sense, of course. In the two groups, we could, without any problem, place the abutment and the provisional. So it is important to understand that it means that when we prepare everything in advance, we could always place the abutment and the crown. So we just had like some minor modifications sometimes to do, but that it was really minor. So sometimes it's a little bit the contact point or a little bit the occlusion. But that was not significant. It's true that sometimes we have a little deviation, and usually the deviation is a little bit buccal. But it's so minor that it's not so problematic, and we can always compensate that with the final crown. And interestingly, in terms of patient-centered outcome, when we ask the opinion of the patient, there were no difference. So it means that for the patient, we don't know really if this was a significant benefit, but yeah, at least the one that had to wear the flipper for 1 week, it was not too much of a problem for them. But I think what is the most interesting from this study, it's the fact that in the test group, we could, in every case, load the implant with the material that was prepared before. So, with this, I come to the end of this muco-integration topic, and to summarize a little bit the take-home message, I would say that we have to keep in mind that peri-implant soft tissue is a very fragile interface, a lot more fragile than a natural tooth. That we have lots of surgical technique to improve the quality and the quantity of soft tissues, and we have to consider that ideally before or simultaneously to implant placement. Eventually we will see how we can deal with that afterwards, but I'm sure this is challenging. And then I want to stress the responsibilities of the restorative dentists and of the prosthodontic procedures, because it's nice to build some nice tissues, but we also have to take care of them afterwards. So, in a nutshell, use biocompatible material transgingivally if you work with bone level implants. Avoid, if possible, completely the disconnection, and if you cannot, minimize them. If you want to work cemented, use custom-made abutment and make sure your limits are not too much subgingival. And finally, design your abutments in order to leave some rooms for the soft tissue with some profile that are rather concave, rather narrow, transgingivally to the profit of the soft tissue. Of course, I also want here to thank, some of the team members, my collaborators from the Pros department, of course the lab technicians that have also an important role in all this. And of course, all the people from my team, from my team that we have now rebranded a little bit our department, which is U Perio, U for University, Perio, because we have a department that is called periodontology, implant surgery, oral surgery. This is very long. And you can actually follow us, not only on Facebook, we also have Instagram and LinkedIn, but if you type on Facebook, for example, periodontology Liège, your career, you're going to find us very easy, and you will be updated with the, with the literature, with the work we're doing, and eventually also the education we're proposing. But of course, this is not finished. We will have a different topic, but this is the first topic. I think it was an important topic for you guys. I understood you wanted to go deep into that. We still have time for questions, and I'm already looking forward for the lecture of our colleague that will a little bit complete the topic with how to deal with complications. So thank you very much.
Yes. Thank you,